Hi all, this is Maya and I am recording my lecture about medication abortion. So let's start. So in general, medication abortion is safe for up to 70 days gestational age. The recommended regimen as of right now is mifepristone plus misoprostol, and we'll talk about doses a little later. However, if Miffy is unavailable, then there are misoprostol-only regimens that should be used. So very exciting and very recently, FDA eliminated key restrictions on abortion pill by removing restrictions on providing mifepristone, and medication abortion can now be sent by mail, which is huge. It is absolutely a huge accomplishment and very exciting news. In the past, you had to sign a contract to be a mifepristone provider, and patients had to physically be there. A lot of the times, physicians had to physically pick up the medication from the pharmacy themselves. So there's been a lot of restrictions that have now been lifted. Mechanism of action. So mifepristone is a selective progesterone receptor modulator. So it binds to the progesterone receptor with affinity greater than progesterone itself, but it does not activate the receptor, so it works as an antiprogestin. It causes decidual necrosis, cervical softening, and increased uterine contractility, as well as prostaglandin sensitivity, which allows for the next step, which is misoprostol. Misoprostol is a prostaglandin E1 analog, and it causes cervical softening as well as uterine contractions, as we know. So when do you use medication abortion? So there are certain conditions that lead providers to prefer medication abortion over surgical, which include the occasion when fibroids are distorting uterine cavity or the cervical canal, when patients have congenital uterine anomalies like a septum or didelphys, etc., or in the event of introital scarring, such as from infibulation, aka female genital mutilation. When not to use medication abortion. So medication abortion is not recommended for confirmed or suspected ectopic pregnancies when a patient has an IUD in place. However, you can remove the IUD and then proceed with a medication abortion. If a patient is on current long-term systemic steroid therapy, if a patient has chronic adrenal failure, if there's a known coagulopathy or anticoagulant therapy, if there's inherited porphyria, or if there's an intolerance or allergy to either mifepristone or misoprostol, then medication abortion should not be used. Oftentimes, providers may not consider medication abortion for patients with anemia, given that we know it causes a large amount of bleeding. However, the safety in anemia is not actually known because studies of medication abortion immediately excluded patients with a hemoglobin less than 10 or 9.5. What to expect. So patients should be counseled regarding what to expect. As always, setting up expectations is the best way prior to proceeding with any treatment. So the most obvious thing to discuss is that patients will experience heavy bleeding, oftentimes much greater than a period, and also will experience strong cramping pain. Some adverse side effects can occur, and these are mostly due to misoprostol and include nausea, vomiting, diarrhea, headache, dizziness, and thermoregulatory effects such as fever, warmth, hot flashes, or chills. These are all things that should definitely be mentioned for patients so that they're not coming back to the ED with things that we know can possibly happen. Patients should also be counseled regarding teratogenicity if failed medication abortion or incomplete abortion happens. This is in the case that if this occurs and patients decide, oh, this is a good thing that have happened because I want to continue the pregnancy. So as far as mifepristone, there's unknown teratogenicity for that drug. However, misoprostol can cause congenital anomalies such as limb defects, with or without Mobius syndrome, which is mostly related to facial paralysis. So how do you evaluate patients prior to a medication abortion? So per ACOG, patients that are evaluated prior to a medication abortion should have their pregnancy confirmed, obviously, as well as their estimated gestational age. However, in patients with regular menses and a very certain LMP, if they are sure they know their LMP, that was within 56 to 63 days, without any sign or symptom or risk factors for ectopic, an ultrasound or clinical exam is really not necessary before medication abortion. Which I found interesting because I think that we really just ultrasound everybody, but per ACOG it's not necessary. RH testing is recommended, and ROGAM is recommended if indicated. Some providers argue that it should be a lower dose. Some providers argue that it's not necessary. So practice differs, but per ACOG, you should give ROGAM if indicated. Now, if ultrasound is needed, then ACOG actually recommends starting with a transabdominal and just really confirming whether or not you have a gestational sac there or you don't. That's really all that their criteria is. If it's really unclear, then they say the next step will be a transvaginal ultrasound. So, what is the regimen for medication abortion? So the preferred regimen and the FDA approved one is giving mifepristone 200 milligrams orally day one. Then the next step will be misoprostol dose, which is 800 micrograms buccally. This is the FDA approved one. And you want to give that 24 hours up to 48 hours later after the 200 milligrams of mifepristone. So now, in the past, patients would have to come into the clinic and you have to watch them take the mifepristone in order to provide them a medication abortion, which is where the exciting news comes in as of December 16th that this is no longer required. And then the other combination, which is WHO recommended, is 200 milligrams mifepristone day one, and then 800 micrograms of misoprostol, but that can be given vaginally, sublingually, or buccally. And again, that'll be 24 to 48 hours later. Now, vaginally giving misoprostol has actually been associated with the least number of side effects, as you recall, the nausea, vomiting, diarrhea that we spoke about earlier. But of course, some people are just not comfortable with placing pills vaginally, so it's whatever your patient chooses. And then in areas where you don't have mifepristone available, remember that you do have a misoprostol only alternative, and that would be 800 micrograms vaginally, sublingually, or buccally, and you repeat that every 3 hours for up to 3 doses. And then another good point is how to give it buccally. So make sure that you have them place 2 pills in between their gums and their cheeks, leave it there for 30 minutes, and then swallow the rest. Okay. So follow-up. Follow-up is not needed unless medically indicated or desired by the patient. If you need follow-up, it can be done by a telehealth visit 1 week later, and you can confirm the success with a urine pregnancy test at home 4 weeks later. If you do decide to do a transvaginal ultrasound, the only purpose should again be, do you have a gestational sac or do you not have a gestational sac? Endometrial thickness does not predict need for subsequent uterine aspirations. And then the other option for follow-up is a pre-treatment HCG level and 1 week after HCG level. And the expected decrease should be at least 80% over the 6 to 7 days, and that indicates a successful medication abortion. What is an incomplete abortion? So an incomplete abortion is when you have a persistent gestational sac without evidence of embryonic cardiac activity or retained tissue. And that's different from an ongoing pregnancy, which would be continuing development with embryonic cardiac activity. However, both can be treated with a repeat dose of misoprostol 1 week after the last dose was given, or by uterine aspiration. The difference is that an incomplete can also be treated with expectant management and just awaiting the body to do its thing. If ultrasound shows thickened endometrial stripe, in absence of excessive bleeding or pain, it can be monitored based on symptoms alone. You do not need to treat and you do not need to aspirate. And finally, contraception. Almost all methods excluding IUD and sterilization can be initiated on day 1, which is mifepristone day, of medication abortion. However, bear in mind that depo may increase risk of ongoing pregnancy because, as we recall, mifepristone is an antiprogestin, and depo has a very high dose of progesterone when injected, and so it could counteract the receptor binding of mifi. So patients should be counseled about that. And most importantly, medication abortion does not have an adverse effect on future fertility or future pregnancy outcomes. Remember that. And that is my talk. My references are ACOG Practice Bulletin number 225 that was recently updated in October 2020. Thank you so much.